cardiovascular system. We will give the characteristics of genetic aspects of coronary heart disease. The next third question, clinical genetics of atherogenic familial hyperlipoproteinemias. We will give the characteristics of the type of inheritance, genes, and etc. The next question of our today's lecture, the main characteristics of polygenic and monogenic forms of arterial hypertension. And the last question, modern genetic approaches to the treatment of arterial hypertension. So, cardiovascular diseases, I hope you know and understood it, are a major cause of health problems and death. World Health Problem. So, in our currently in the situation with the COVID infection, the patient has the serious consequences affecting the cardiovascular system also. And in generally, cardiovascular diseases cause more than half of all deaths across the European region. Hereditary pathology of cardiovascular system, we may divide into the several types or classes. Start from hereditary cardiomyopathies. There are several forms. Hypertrophic cardiomyopathy, dilated cardiomyopathy such as familial dilated cardiomyopathy, desminopathy, dystrophinopathy, like a muscular dystrophies of Duchenne, Becker-Barth syndrome, etc. Sarcoglycanopathy. So also hereditary cardiomyopathies include arrhythmogenic right ventricular tachycardia, restrictive cardiomyopathy, and also includes the unclassified types of the cardiomyopathies, such as mitochondrial pathology or mitochondrial diseases, glycogenosis, and etc. Cardiomyopathies are disorders of the myocardium that arise from a variety of etiologies and culminate in hypertrophic or dilated remodeling of the heart. While compulsory forms of cardiac remodeling are recognized, inherited and de novo genetic variants are the most prevalent causes for primary cardiomyopathies. Important insights into the genetic cause and molecular pathophysiology have had a profound effect on our understanding of basic myocytes biology and their personalized approach to managing the disease. Hereditary cardiomyopathy is inherited as an autosomal dominant trait, then conveys a 50% risk of transmission to offspring. Familial studies and subsequent genetic epidemiological analysis have demonstrated that pathogenic in sarcomere protein genes are found in approximately 60% of patients with the clinical criteria for hereditary cardiomyopathy. However, most disease-causing variants occur in myosin-heavy chain and myosin-binding proteins, C. And you may to see their short name or abbreviature of the genes which determine these proteins, and polymorphic loci in this gene involves into the pathogenesis of this type of cardiomyopathies. The identification and subsequent characterization of gene mutation associated with the genetic cardiomyopathies have identified key pathways involved in the development of abnormal cardiac morphology, such as deficits in force transmission and generation, energy utilization and regulation, and intracellular calcium handling. This advancement have begun to impact clinical management and the development of new medicines for genetic cardiomyopathies. The next group of hereditary diseases includes primary cardiac arrhythmias, such as syndromes accompanied by lengthening of the QT interval, syndromes accompanied by shortening of the QT interval, catecholaminergic polymorphic ventricular tachycardia, Brugada syndrome, and the some ceteris. So, primary cardiac conduction disorder includes progressive violation of the conduction of the heart, sinus node dysfunction, atrial fibrillation, Wolff-Parkinson-White syndrome. Next group of congenital or hereditary diseases of cardiovascular system are congenital malformations with a violation of the division of the cavities of the heart. For example, ventricular septal defect, atrial septal defect, and etc. Congenital malformation with impaired division of the arterial trunk, such as common arterial trunk, complete transposition of the pulmonary artery and aorta, stenosis and atresia of the pulmonary artery and or aorta, coarctation of aortic isthmus, and etc. During your practical classes in genetics, medical ecology, we will give more detailed characteristics of the congenital malformation of the cardiovascular system. Combined congenital malformation of the heart, for example, maybe trilogy, tetrad, pentad of Fallot. A large number of different malformations are known, for which the gene which determines them have been identified. On this chart, you need to see some examples of the congenital malformation of the cardiovascular system. You need to see the name of the gene which associated with this disorder, gene function, and number in OMIM. I repeat, and I want to remind to you that you need to use the database, genetic internet database, online Mendelian inheritance in man for genetic characteristics of some pathology, some hereditary diseases. For example, you might use it for the characteristics of the congenital malformation. For example, we talked with you about the tetralogy of Fallot. The several genes associated with this pathology, for example, GATA4, the gene function, member of the GATA family of zinc finger transcription factors, through to regulate genes involved in embryogenesis and in the myocardial differentiation and function. So I hope you know that there etiology and of all congenital malformation happens during the embryonic development of some individuals, and we need to detect it in newborns. So, most chromosomal syndromes are accompanied by congenital heart defects. For example, in case with the Down syndrome, approximately 40% of patients with Down syndrome will have a congenital heart defect. Also, we are detected the presence of the congenital malformation of their hearts in case with the Edwards syndrome, Patau syndrome, and in ceteris microdeletions or microduplications syndromes. Also, we know about the rare combined heart defects, such as Lautenbach disease, Eisenberger's disease, blunt-white or Garland's disease, others diseases like a primary pulmonary hypertension. The next name are Erlanger syndrome and Escudero disease, cyanosis, black and etc. However, our most common forms of cardiovascular diseases are atherosclerosis and arterial hypertension. Among atherosclerosis, there are cardiac ischemia, ischemic brain diseases, obliterating atherosclerosis of peripheral vessels. Arterial hypertension include hypertonic disease and symptomatic arterial hypertension. Main mechanisms of development of atherosclerosis and coronary heart disease. So, in case with the coronary heart disease, atherosclerosis, coronary arteries registered in 90% of all cases. It is the main pathogenic mechanism of the formation of the coronary heart disease. It depends from the lipid metabolism disorders such as hypercholesterolemia, hyperlipoproteinemia, which depends from mutation or unfavorable combination of genes that control lipid and lipoprotein metabolism, influence of the environment risk factors. Coronary heart diseases in general, it is a common or multifactorial pathology, but some forms of the coronary heart disease has a monogenic inheritance. We will give more characteristics of them. So, let me remind you the main classes of basic lipoproteins involving in atherosclerosis. I hope you're reminded from the biochemistry, from the pathophysiology, but the main basic lipoproteins are chylomicrons, very low density lipoproteins, low density lipoproteins, high density lipoproteins, upper R1, upper R, upper B100, upper E, upper C. It is the basic atherogenic apolipoproteins. Apolipoproteins has very important functions, such as from structure of lipoproteins, transport of lipoproteins in the bloodstream from place of their synthesis to the peripheral tissues, transport of cholesterol from peripheral tissues to the liver for metabolizing and excreting, promotes the interaction of lipoproteins with specific receptors on the cell membranes, and regulate an activity of enzymes of the lipid metabolism. The next information very important about the for prevention of atherosclerosis and coronary disease, about the classification of the risk factors for atherosclerosis and ischemic heart disease. There are several groups. First of all, risk factors with strong genetic contribution. Risk factors with a strong genetic contribution include positive family history of early ischemic heart disease in first-degree relatives, increased level of total cholesterol in the plasma, high levels of low-density lipoproteins in plasma, high levels of LDL cholesterol ratio, decreased level of high-density lipoproteins in the plasma, low level of HDL cholesterol. On this chart, you may just see there a recurrent risk in persons for the ischemic heart disease in men, estimated using an information about first-degree relatives. You may just see in first column their current age, years old, and parents may be unaffected, maybe only one affected, maybe both affected, and number of affected siblings. In our current age, 20-29 years, in unaffected parents, their recurrent risk for ischemic heart disease approximately only 2%. But in comparisons with the current age 50-59, if not affected parents have the risk increase in 5 times, 10%. And you may just see in case when the both parents are affected and the age of their individual 50 years, the recurrent risk of the development of the ischemic heart disease are maybe 63%, very high risks. Also, the risk factors with a strong genetic contribution include low activity of LDL receptors, registered mutations in apolipoprotein, ApoB100, high level of lipoprotein A in the blood, presence of apolipoprotein ApoE2 type, presence of essential hypertension or diabetes mellitus, and combination of erythrocyte antigens. Next, second group of risk factors, named risk factors with potentially informative genetic contribution, include positive family history of ischemic heart disease in second-degree relatives, high level of very low density lipoproteins in the plasma, hypertriglyceridemia, disorders in the blood coagulation system, such as high level of fibrinogen, high level of thrombin, low level of endogenous heparin, and decreased activity of fibrinolysis. Also, the risk factors with potentially informative genetic contribution includes increased levels of insulin in the plasma, impaired glucose tolerance, low level of estradiol in the plasma, abdominal obesity, heterozygous carriage for homocystinuria mutations, and combination of HLA antigens. Next, third group, risk factors without genetic contribution. It is environmental risk factors, such as smoking, food overconsumption, hypodynamia, life stress, and conservative steroid administration. For early prevention of any cardiovascular diseases, we need to recommend it to the patient avoid environmental risk factors. So now let's give the more detailed characteristics of ischemia heart disease, cardiac ischemia. Acute or chronic disease resulting from a decrease or cessation of blood supply to the myocardium due to damage in the coronary artery system. Sifra, please switch on, switch off phones. Everyone, please switch off your phones. Mohammed Afif bin Mohammed, switch off your phones and other students.
Sorry, madam.
Okay, so ischemic heart disease is the leading cause of death in the population worldwide. 5 out of 10 new cases of myocardial infarction occur before the age of 50. The risk of developing coronary artery disease after 40 years is 32% in women and 49% in men. Cardiovascular diseases, it is a group of the disease with the genetic heterogeneity. There are some cardiovascular diseases may have the single gene inheritance or Mendelian inheritance. Some of them may have the complex includes a complex group with the additive polygenic inheritance. For example, in case with hypertension, monogenic inheritance has a maximum 20% of all cases, 80 to 90% it is their type of the hypertension with the additive polygenic inheritance. In case with the mitral valve prolapse, up to 90% has that single gene inheritance or monogenic inheritance, and additive polygenic inheritance are about 10%, because the mitral valve prolapse, it is like a typical congenital malformation. And genetic heterogeneity of the cardiovascular diseases depends from there are two groups of the pathology, polygenic forms and monogenic forms. In cardiac ischemia, monogenic forms in which the risk of developing the disease is associated with the presence of variants in a single gene or in small number of the genes, or oligogenic inheritance, we may name it. The examples of familial hypercholesterolemia, whose appearance is determined by the sequence variants in a described group of genes. LDLR genes, ApoB, PCSK9 genes, and etc. The next second group, polygenic or complex group, in which disease risk is determined by multiple genes, numerous variants of these genes, and the interaction with environmental factors. Monogenic forms of ischemic heart disease depends from the mutation in single genes which involved in the regulation of lipid metabolism. It involves into the formation of the severe lipid metabolism disorders, hypercholesterolemia, etc. Rapidly progressive atherosclerosis of the coronary and other arteries depends from the disorders of lipid metabolism. Atherosclerosis involves in early development of coronary heart disease, systemic atherosclerosis. The best known examples of Mendelian lipid disorder is familial hyperlipidemias. There are heterogenic groups include hyperlipoproteinemia type 1 or lipoprotein lipase deficiency. More common group are hypercholesterolemia type 2A and 2B, hypolipoproteinemia type 3, hypertriglyceridemia type 4, and hyperlipoproteinemia type 5, hyperchylomicronemia. More detailed characteristics of the type 2A. It is their common autosomal codominantly inherited genetic disease that leads to abnormally high levels of circulating low-density lipoproteins, cholesterol, and early development of ischemic heart disease, among the other cardiovascular diseases. The common forms is a heterozygous form, where an individual has one defective copy of a gene involved in the cholesterol metabolism and has a prevalence between 1 in 250 or 1 in 50 individuals. These patients tend to develop premature cardiovascular disease in the middle age. They develop cardiovascular diseases that is clinically apparent by the teenager years, sometimes early. Genetic variants of familial hypercholesterolemia. There are different forms, includes first of all, familial hypercholesterolemia due to a deficiency of defect of other receptors or receptor form, mutation and LDLR gene. Also, familial hyperlipidemia due to the structural defects of ApoB100, the gene, ApoB gene. So the next type, due to type 9 subtyrosine casein protein convertase mutation, and the name of the gene presented here. And there are some patients with the familial hypercholesterolemia type 2A may have the polygenic inheritance. On this slide, you need to see the proportion of cases of some familial hypercholesterolemia genes, which involves into the determination of the genetic heterogeneity of these 2A forms. Pathogenetic variants in 3 genes cause the vast majority of familial hypercholesterolemia. The most common of which is LDLR, that normally encodes the LDL receptors and is responsible for 60 to 80% of this type of hypercholesterolemia. Pathogenetic variants in their ApoB gene that leads to a defective apolipoprotein B and in inability for the LDL receptors to take up LDL-C are responsible for 1% to 5% of these cases. And finally, an gain-of-function variants in the PCSK9 gene leads to the overexpression of the protein, this protein, and overdegradation of the elder receptors, and is responsible for 3% of causes overall. Around 20% of individuals with their familial hypercholesterolemia don't have the identifiable genetic variants and are likely caused by variants in genes that are not yet discovered. Prevalence of familial hypercholesterolemia heterozygous 1 from 250 persons, homozygous more rare, and 1 for 1 million individuals. Type of inheritance, autosomal dominant, the different mutation in LDLR genes. The frequency of heterozygous among patients with a myocardial infarction is 1 from 20. Relative risk of coronary artery diseases is 10 to 20 times higher in patients with the receptors variants of familial hypercholesterolemia than without it. Pathogenesis of receptor variant of familial hypercholesterolemia, we need to divide it into there are two types. First of all, LDL receptors are not synthesized, and LDL receptors are synthesized, but they're unable to link with the LDLs. In this case, LDL receptors are synthesized that are able to link with LDLs, but the releasing of cholesterol from the LDLs is impaired. It involves into the formation of the defects of LDL receptors and increasing both cholesterol and LDL in plasma. In first case, LDL receptors are synthesized by the migrate slowly from the reticular network to the Golgi complex. It involves into the formation of the deficiency of LDL receptors and involves in increasing both cholesterol and LDL in plasma. So, clinical manifestation of receptor variants of familial hypercholesterolemia are males and females are affected with identical frequency. Cholesterol metabolism abnormality signs are bright yellow tuberous dermal xanthomas at areas of Achilles tendons, plantar xanthomas between first and second choice, canal arcus lipoids, and periorbital xanthelasmus. Onset of ischemic heart disease in homozygous before 20 years, in heterozygous after 40 years. On this slide, you will see the photo of the patient with xanthomas and papillus or nodules on the skin or mucous membrane that contain lipids. You might see it like this one on the neck, and etc. Tuberous xanthomas at the extensive areas of knee joints, you may see. And xanthomas at areas of hands and fingers. So with the coding of our reglement of the lecture, now you will have 10 minutes break, and after that we continue. Do you hear me, guys?
Yes, ma'am.
Okay, 10 minutes break.
Okay.
So please, let's continue. Do you hear me, guys?
Yes, madam.
Okay, very good. So, the next form of familial hyperhorseonemia, it is just a moment. Yeah, is due to ApoB100 defects, two rare forms, prevalence 1 from 500 individuals, autosomal dominant type of inheritance, clinical manifestation as an receptor variant of familial hyperhorseonemia, onset after 50 years. Pathogenesis start from the inherited or the mutations in gene encoding ApoB 100, weakening the interaction with the LDLs with the specific receptors at peripheral tissues, delayed elimination of LDLs from circulations, and involved into the increasing LDL in plasma, increasing cholesterol in LDLs, and generally involves into the hypercholesterolemia. Next form is polygenic hypercholesterolemia, unknown prevalence but widespread, additive polygenic type of inheritance, main clinical manifestation. In this case, xanthomatosis is not characteristic, association with essential hypertension and diabetes mellitus. Onset after 40-50 years. Strong clinical variability of ischemic heart disease manifestations are characterized of polygenic variant. Laboratory diagnosis of familial hypercholesterolemia. So receptor variant are characterized by the next plasma cholesterol levels in heterozygous 40 to 50 milligrams, in homozygous more high levels till 1000 milligrams, characterized by increased levels of LDL in plasma, absence of functioning LDL receptors, and for molecular diagnosis, identification of 1 or 40 common mutations in the gene coding LDL receptor. Laboratory diagnosis of familial hypercholesterolemia due to a defect of ApoB100. Plasma cholesterol level are heterozygous till 500 milligram, homozygous till 1000 milligram. Increased levels of LDL in plasma, increased levels of LDL cholesterol criteria, normal functioning LDL receptors, delayed clearance of LDLs from circulation, and for molecular genetic testing, identification of mutations in the gene coding ApoB100. So, laboratory testing of polygenic forms. Levels of plasma cholesterol 240 till 400 milligrams, presence increased levels of LDL in plasma, but normal functioning LDL receptors, not detected mutation in a gene ApoB100, and presence of the special ApoE4 allele. Next form, general form of familial hypercholesterolemia 2B form, characterized by the genetic heterogeneity, prevalence from 100 to 300 individuals, frequency among patients with the early ischemic heart disease, 10%, with their autosomal dominant type of inheritance with a high penetrance. Some cases may have the additive polygenic type of inheritance. Clinical picture, xanthomatosis not characterized, xanthomesmas, canal erythrocytoids presence, abnormal glucose tolerance test detect. Onset after 40-50 years, and combine hyperlipidemia, isolated hypercholesterolemia, and hypertriglyceridemia among relatives of proband. Laboratory testing, plasma cholesterol level till from 300 till 400 milligrams, plasma triglycerides 200 till 500 milligrams. Characterized by increased levels of LDL and VLDL in plasma, possible decreasing in HDL level, increasing ApoB level in both proband and his or her relatives, and detection of presence of the alleles ApoC3, ApoA4, and mutation in lipoprotein lipase genes. So therapy of familial hyperlipidemias includes, first of all, changing lifestyle, arrest of smoking, physical exercise, body mass control. Very important, diet therapy. To limited consumption of food rich by cholesterol, saturated fatty acids, carbohydrates, salts. To increase consumption of food enriched by polyunsaturated fatty acids, and also cellulose and composites, carbohydrates, and vitamins. Therapy includes, of course, hyperlipidemic drug therapy, for example, statins, fibrates, cholesterol, nicotine acids, propofol. May used afferent therapy, and in this case, possible gene therapy. It's possible for receptor variant of familial hypercholesterolemia. Polygenic forms of ischemic heart disease are based on combination of multiple genetic variants with environmental factors. It is a typical form with hereditary predisposition. The combination of the multiple genetic variants which inherited from our parents, if it's associated with a negative environmental risk factors, it involves into the abnormal lipid and carbohydrate metabolism and hypercoagulation. It involves in atherosclerosis and thrombosis and development of coronary heart disease and comorbid pathology. Comorbid pathology like diabetes mellitus, hypertension, obesity, strokes. And nowadays, we know about the large number of genetic studies had been carried out that have identification candidate genes. There are some candidate genes such as genes involved in the regulation of lipid cholesterol metabolism, genes involved in the control of hemostasis, genes that control vascular hemostasis, genes for general metabolism, and genes involved in the regulation of inflammation. First of all, genes involved in the regulation of lipid metabolism, such as apolipoprotein E gene, gene of lipoprotein lipase, apolipoprotein B gene. Genes are affecting their exchanges of LDL, for example, LOX1 gene. Also, the examples of the genes involved in the control of hemostasis, which associated with this pathology, glycoprotein complex gene, IA and TUR-A genes of factor 5 and prothrombin factor, like detection of Leiden mutations, gene of inhibitor type 1, plasminogen activator. These examples of the gene which are associated with the ischemic heart disease. So, genes that control vascular hemostasis and associated with ischemic heart disease are endothelial synthase gene, NOS3, gene of angiotensin converting enzymes, gene angiotensin gene, angiotensin receptor gene type 1, and aldosterone synthase gene, the gene cytochrome system. Also, genes for general metabolism, which associated with ischemic heart disease, are gene methylene tetrahydrofolate reductase, genes for alcohol dehydrogenases, catalase gene, gene glycogen peroxidase type 1, genes of glycogen transferase, their glycogen 1 system in generally, you may just see. Also, we know about some genes which involved in inflammatory response and associated also with ischemic heart disease are gene of interleukin 6, interleukin 15, 78, gene of interleukin 9 receptor, gene of the SD163 molecule. So I want to remind you the special internet genetic database in which you may to see the whole information about the genetics of the cardiovascular diseases. For example, GWAS catalog of Genome-Wide Research Association, online catalog of human genes and genetic disorders, online Mendelian inheritance in man. CleanWire database contains information on genomic variation and their relationship with human health. Sequence variant nomenclature, database on the interpretation of functional effects of the gene cuts. So the most common cardiovascular disease is arterial hypertension. Multifactorial disease characterized by a persistent chronic increase in systolic and or diastolic blood pressure, which is based on polygenic genetic mechanisms that cause high activity of long-acting pressor mechanisms. Primary hypertension tends to be familial and is likely to be the consequences of an interaction between environmental and genetic factors. Prevalence of essential hypertension increases with age, and individuals with relatively high blood pressure to younger age are at increased risk for the subsequent development of hypertension. You may to see the contribution of genetic factors to total phenotypic variability of blood pressure. In a general healthy human population, genetic components like additive components involved in systolic blood pressure is 2.3%, but in case with a hypertensive human population, the additive components approximately 70%. The dominant components detect only in case with diastolic blood pressure in hypertensive patients. So, in the table, you may to see the relative risk of developing arterial hypertension in the population and among relatives of patients with hypertension. So, according to family studies, the heritability coefficient of hypertension ranges from 15 to 35%. Genetic heterogeneity of hypertension depends from the prevalence of polygenic forms, approximately 90%, and monogenic forms. Of the patient depends from the special diet and susceptibility genes in individuals, depends from the age of the patient and susceptibility of the genes, or in another words, depends from the special individual hereditary predisposition of the some patients, some individuals. Also, the blood pressure depends from the body mass and special genes and environmental influence and susceptibility genes which are required, for example, for detoxification of the some xenobiotics which may injure to their humans. So, the main characteristics of polygenic hypertension are high frequency in population. They compose about 95% among all hypertension. They comprise essential hypertension and majority of symptomatic hypertension. Additive polygenic type of inheritance. Recurrent risk for offspring is estimated by empirically. Non-specific environmental factors play a significant role in the development of hypertension. Sex differences in disease susceptibility, the frequency of polygenic forms in females are higher than in males. The severity of polygenic hypertension in males is greater than in females. Age of manifestation is usually after 40 years old. Polygenic hypertension associates with ischemic heart disease, diabetes, and obesity. Polygenic variants develops as a result of generalized rising of vascular tone, and various combination of antihypertensive drugs are used for therapy of hypertension. Characteristics or some special characteristics of pedigree data influencing the risk estimation for essential hypertension. So, number of relatives affected by hypertension, relatedness of proband to affected relative, presence of hypertension among greatly affected individuals, for example, in males, age of hypertensive manifestation in relatives, severity and course of hypertension in relatives, presence of disease complications in pedigree, and presence any of ischemic heart disease, obesity, polymorphic arterial hypertension among relatives. So, clinical feature of hypertension in individuals with their positive family history of disease. Primary manifestation of high blood pressure rise in 80 years early in patient with a positive family history of hypertension than in patient without one. The severity of disease in proband is directly proportional to the number of affected relatives and their relatedness to proband. The course of hypertension is usually progressive and frequently with malignant tendency and early complications. Prognosis is unfavorable. Marked elevating the blood pressure and developing the insufficient contractile capability of myocardium with subsequent heart failure. Poor or absent of efficiently from the additional hypotensive therapy. High doses of hypertensive drugs are required to control of blood pressure. So there are genetic or hereditary predisposition to their polygenic arterial hypertension. We may to divide it into there are two main group of the gene, like a major gene, such as genes for the regulation of the kallikrein-kinin system, or genes for the regulation of the membrane ion transport, or genes for the regulation of the carbohydrate metabolism, and genes regulating lipid metabolism, and maybe a factor which increase the risk of the disease in some individuals. For example, genes for regulation of the renin and angiotensin system are the genes water salt metabolism disorders and etc. And in these general schemes, presence its possible effects and mechanism of the detection of the predisposition to this polygenic variants of the arterial hypertension. So the next form of arterial hypertension, monogenic hypertension. They compose about 5% among all hypertensions. The development is the result of single gene mutations. All cases of monogenic form has Mendelian type of inheritance. Recurrent risk for offspring is estimated depending on the type of monogenic inheritance, like autosomal dominant or autosomal recessive type. Environmental factors are specific and play non-significant role in the development of hypertension. So, there is no differences in disease acceptability between males and females. Age of manifestation is usually before 40 years old. Average manifestation age is 20 years old, maybe earlier. Malignant course of hypertension develops as a result of accelerated reabsorption of sodium and water in kidneys. And using single specific antihypertensive drug is therapy of monogenic hypertension. Classification of monogenic hypertension include Liddle syndrome or pseudoaldosteronism, glucocorticoid-remediable aldosteronism, apparent mineral corticoid excess, familial glucocorticoid resistance, Gordon syndrome, brachydactyly and hypertension syndrome, congenital adrenal hyperplasia type 4 and type 5, familial pheochromocyte tumor, multiple endocrine neoplasia type 2. More detailed characteristics for the Liddle syndrome, and you might see the OMIM number for detailed characteristics. Liddle syndrome is a severity hereditary form of hypertension characterized by increasing reabsorption of sodium and water in the renal tubules due to excessive activity of epithelial sodium channels, a decrease in the content of potassium, renin, and aldosterone. Patients have an increased sensitivity of blood pressure to the intake of salt. An important clinical feature of the syndrome is the fact that suppression of excessive activity can only be achieved with the use of diuretics containing amiloride. On this slide, you might see the epithelial cells in distal tubules of kidney where sodium and water are reabsorbed. Increase reabsorption of sodium in water and mineral corticoids involves into the aldosterone and receptors and it involving into their fifth-fold increased activity of the channels. Liddle syndrome involves abnormal kidney function with excess reabsorption of sodium and loss of potassium from the renal tubule and is treated with their combination of low sodium diet and potassium sparing diuretic drugs. The reasons for the high activity of the channel is there mutation in the amino acid sequences and using the DNA diagnostic methods, various types of mutation, like a missense mutation or frame shift mutation, or in the genes encoding the structural subunits of sodium channels have been identified. Diagnosis of Liddle syndrome is often suspected based on the presence of early onset hypertension with a high blood pressure, especially in people with a family can then be ordered to confirm the diagnosis. This may include a blood test which can detect low levels of potassium, renin, and aldosterone, urine test to identify low levels of sodium and aldosterone, and genetic testing to look for changes or mutation in their special genes, which involved into the formation of the Liddle syndrome. The next examples of monogenic forms of arterial hypertension is glucocorticoid remediable aldosteronism. So, hyperaldosteronism, familial type 1, for example. It is a typical autosomal dominant disorder characterized by hypertension, variable hyperaldosteronism, and abnormal adrenal steroid production, including eating oxocortisol and 18-hydrocortisol. There is significant phenotypic heterogeneity, and some individuals never develop hypertension. So, mutation in gene cytochrome 11b1, gene of cytochrome P450. Now we know about the familial hyperaldosteronism type 2, familial hyperaldosteronism type 3, and familial hyperaldosteronism type 4. You may to read more detailed characteristics of it in AMIM using the AMIM number or the name of the different type, which forms the genetic heterogeneity of familial hyperaldosteronism. Molecular mechanisms are present on the slide and involves into the presence of the formation of mutation like a chimeric gene, which involves into the formation of aldosterone-like protein, which involves into the synthesis of aldosterone-like protein, which detect hypertension. The next question of our lecture, pharmacogenetic approach to therapy of essential hypertension. Determination of genotypes responsible for individual sensitivity to antihypertensive drugs using for traditional treatment of essential hypertension. Using genetic to characterize response to pharmacological treatments offers a new approach to tailoring antihypertensive treatment to a given patient. The goal of pharmacogenetic studies is to enhance the understanding of the genetic nature of drug response based on the interaction of individual genetic architecture and antihypertensive therapy. Hypertension susceptibility genes may interact with a type of antihypertensive medication to modify blood pressure response to treatment and risk of coronary heart disease. There is large individual variability in response in efficacy and tolerability to various classes of antihypertensive agents, and often hypertensive patients are refractory to particular drugs. On the slide presents the blood regulation pressure system, examples of the genetic polymorphism in the some special gene, its phenotypic association, and postulated response to a pharmacological agent. It involves into the titrating treatment to the genetic components of pathogenesis, may enhance treatment efficacy and improve overall benefit, resulting quality and better use of limited economic resource. with according of the knowledge of genetic susceptibility and about the genetic polymorphic variant of the some gene, we may make the pharmacogenetic approach to therapy of essential hypertension, which depends from the activity of the some gene, its product. For example, angiotensin gene. This gene determines individual sensitivity of blood pressure to the action of the ACE inhibitors. So, alpha-adenosine, this gene determines individual sensitivity of blood pressure to the action of thiazide diuretics. Gene B3 gene. This gene determines individual sensitivity of blood pressure to the action of beta blockers, for example, to anaprylene. Angiotensin converting enzyme. This gene determines individual sensitivity of blood pressure to action of both the blockers of type 1 angiotensin receptors as sartan and ACE inhibitors. The gene which localizes on the second chromosomes determines individual sensitivity of blood pressure to action of calcium channel blockers, for example, nifedipine. So, today we told that for the treatment of the some monogenic forms, we need to use the gene therapy. Gene therapy correction of the gene in there some individual, and it induction of expression of the gene of nitric oxide synthase, for example, and etc. So, gene therapy for hypertension and its vascular complication, we need to divide it into there are two types. Systemic treatment to lower blood pressure and local molecular therapeutics to reverse vascular complications. So, systemic treatment involves vasodilator genes, insertion of gene copies with a plasmid DNA or viral vectors, and vasoconstriction gene antisense inhibitors, for example, antisense oligos or antisense DNA in viral vectors use. In case with the local molecular therapeutics to reverse vascular complication, includes vasodilators, antioxidant genes, insertion of the gene copies, for example, use viral vectors, and genes for inducing angiogenesis, insertion of the gene copies using plasmid DNAs and viral vectors. So now our lecture is over. Thank you for your attention. If you have questions, I will be explained. I'm listening to you. I hope all group leaders wrote in a chart the names of the students who's not linked. Yeah. So do you have a question? Do you have a question about the lecture or about some another situations? Not yet.
No, madam.
Okay. Again, thank you for your attention. Good luck to you and God bless. Now you may be free. You may switch off Zoom. До свидания.
До свидания, madam.
До свидания.
Bye.
До свидания.
До свидания.